Good morning, everyone. Welcome to Grand Rounds. It's my great pleasure this morning to introduce my friend, colleague, and an incredibly accomplished investigator and leader, Dr. Kirsten Bibbins-Domingo. Dr. Bibbins-Domingo received her PhD in biochemistry from UCSF, followed by her MD and eventually a master's in advanced studies. She completed her internship, residency, and a general internal medicine fellowship at UCSF and then joined the faculty. Dr. Bibbins-Domingo is professor and chair of the Department of Epidemiology and Biostatistics and the Lee Goldman, MD, Endowed Professor of Medicine. She's the inaugural Vice Dean for Population Health and Health Equity at the UCSF School of Medicine. Dr. Bibbins-Domingo co-founded the UCSF Center for Vulnerable Populations at the Zuckerberg San Francisco General Hospital that generates actionable research to increase health equity and reduce health disparities in at-risk populations in the San Francisco Bay Area, California, and nationally. She co-directs the UCSF Clinical and Translational Science Institute and leads the UCSF COVID Community Public Health Initiative. She is a general internist, cardiovascular disease epidemiologist, and a national leader in prevention and interventions to address health disparities. She is an NIH-funded researcher who uses observational studies, pragmatic trials, and simulation modeling to examine effective clinical, public health, and policy interventions aimed at prevention. Dr. Bibbins-Domingo was a member of the U.S. Preventive Services Task Force from 2010 to 2017 and led the task force as the vice chair and chair from 2014 to 2017. She is an inducted member of the American Society for Clinical Investigation, the Association of American Physicians, and the National Academy of Medicine. We are so fortunate to have her here this morning to speak to us about equity and effectiveness during the COVID pandemic. Thank you so much, Dr. Bibbins-Domingo.
Thank you very much, Simrajot. It's a real pleasure. Simrajot and I are friends from medical school. Simrajot got me through medical school, and I always enjoy my visits down to San Diego when she invites me down. And unfortunately, we have to do it virtually this year, but I hope to have an invitation to come down again and be with you all in person at some point in the future. So I want to talk about equity and effectiveness, but I thought I'd give you just a sense of what I was doing at the start of the pandemic and weave together the three threads that got me into this work, which is not what I had been doing prior to the pandemic. So when the pandemic hit, I'm not an infectious disease expert, and I had plenty to do institutionally as chair of the Department of Epidemiology and Biostatistics. And so I decided that what I would do during the pandemic was to, make sure my department was running and to be a doctor. Because we had obviously massive clinical needs. Many of our residents deployed to the inpatient services, and so that I would be an outpatient physician. That was going to be my contribution. And I think three things happened that actually led to this line of work that I'm going to talk about today. I practice at San Francisco General Hospital. It's a safety net hospital in San Francisco. And so the three things that came together are, number one, we quickly realized how many of the COVID patients that we had coming through both our outpatient clinics and in our hospital were Latino patients. Substantially out of proportion to even how many Latino patients we normally see in our practice. So pretty quickly, the theme of disparate impact and health disparities was emerging, which is an area that I work in. The second was really trying to understand how the lockdowns that we were in were going to affect many of our patients who had less means. I still remember one patient I precepted in clinic, or a nurse practitioner I worked with in clinic, who was in tears because she had a patient who had had a renal transplant several years back, who had been admitted to the hospital for something fairly minor. But following the admission, they were trying to do med reconciliation, and she was trying to do this all remotely with a patient who was marginally housed, who had limited understanding of his medicines. And she was in tears because she said, this patient is going to die during the pandemic. He's not going to die of COVID, but he's going to die because we're not going to be able to figure out how to get him back on his post-transplant medications. And so the last thing that came together was I was called in clinic to ask to certify a death certificate, as we often are in primary care practice. And the funeral home called me and they asked me to certify the death certificate. I, of course, as is often the case, didn't really know what this elderly man had died of. The family told me some of the events around his death. And I realized that I had no idea whether he actually had died of COVID or he had died of something else. And that is also something that happens often when patients die outside of the hospital. And so the three things together led me to think, wow, we really need to understand how the real impact of this pandemic, particularly for those who are the most marginalized, in order to both understand the pandemic and to understand what we need to do to keep all of our population safe. And so this has led to a line of work that I've really enjoyed, is very different from what I normally do, but I think speaks to many of the strands that come together even post-pandemic, of how we take care of our most vulnerable patients, how we collect data and feed data back to public health, how a pandemic response and a public health response has implications for how we practice clinically. And so it's one of those themes that I'm going to point to at different points in this talk, and hopefully we'll have time to have some more discussion about this afterwards. So let me see if I can advance my slides. Oh, yeah, good. So these inequities, here I'm showing by race, ethnicity, are pretty well described during the pandemic. Probably less well recognized, if you're not steeped in disparities literature, is that this graph, which is showing higher rates of hospitalizations during the pandemic in Black and Latino and American Indian patients, is that this is actually a graph from not this pandemic, but from our last pandemic 10 years ago. And for those people who study pandemics, they will tell you that this is what you expect to see. You expect to see a disparate impact. You expect that those communities that have the most resources will be able to mobilize those resources to keep themselves safe during the pandemic, and those with the least will be less able to do that. And that, in fact, a hallmark of good pandemic preparedness is to recognize these disparities that they're going to happen, and to actually figure out ways to mitigate it. Because, of course, although disparities are common and we see them across many health states, in a pandemic where you have a communicable disease, it is pretty clear that the ability to transmit a disease from one person to another during a pandemic doesn't respect the normal boundaries of the ways we live, the ways we interact, the ways we work, and that we really have to make sure that our most marginalized patients are safe, both because it is our societal, ethical, and professional responsibility, but also because it really doesn't help in terms of an effective response for keeping transmission rates low. And that's the theme that I want to elaborate throughout. So pretty early, I wrote about this, that this is something that we see time and time again, but this time hopefully would be different. It should be different because we have because we are globally interconnected, because we are locally interconnected, because we have a massive co-occurring economic crisis that is going to make those who are most marginalized be at greater risk, and that we have to think differently. Unfortunately, of course, we know that probably hasn't happened to the degree it needs to in order to have gotten us through this pandemic, and that's what we're going to talk about today. So the main tool that I tried to deploy with my colleagues when we were concerned about thinking of the disparate impact that the pandemic, as well as the lockdowns and the shutdowns that were the public health response to the pandemic, were going to have, was to understand how many more people died in any given week than we would have expected to die had the pandemic not been in place. These are called time series analyses, and these are excess deaths. And it was a great feat of collaboration between my colleagues who were at CDPH and at the California Department of Public Health, and who were at UCSF to figure out early on how to make these data available, and something I'm very appreciative of the state for making available. So the gray lines here, these are death certificate data. The gray lines represent the trends in deaths at every given week in every prior year. And the red line shows how many more deaths happened in that year, in last year, in that week during last year than one would expected based on historical trends, right? So historical trends are represented in the green, and the excess deaths are represented in red. And we're focused on excess death and not just COVID diagnosed death, because we know that people weren't diagnosed with COVID. We know that people might have died of pandemic related deaths because of the lockdown, but weren't infectious disease deaths. We wanted to capture the full impact. And that's what I'm going to describe throughout. So what you're seeing here is the first lockdown, the first phase. After the lockdown, deaths coming down, the reopening, and then of course in the summer, the resurgence of the summer surge there again. So first we asked, well, how have we done in terms of the racial and ethnic disparities? And the key observation here is that Black Californians, who make up a smaller percentage of the population of California, about 6% of the population, have had the highest per capita deaths throughout the pandemic, and certainly early on. You can see it most clearly in this lower panel. This is the early lockdown months, and you see the highest per capita deaths in Black Californians. The striking pattern in Latino Californians is this is the only racial and ethnic group that didn't experience a decline in deaths as a result of that first 2-month lockdown period. So you see that most clearly in the top panel, whereas most groups come down in terms of deaths during those first 2 months of lockdown. Latino Californians actually have high excess mortality, never comes down, and stays high, and then rises substantially as we get to the summer months. And as you probably are aware, even when we look at, we see these numbers substantially high when we restrict just to COVID deaths, or when we look at overall excess mortality. Latino Californians really account for more than 50% of the excess mortality in the state, even though they're about 39% of the population. We can look at this a different way, and not just by race and ethnicity, and this is education level. Education is oftentimes a proxy for socioeconomic status. You can think about this as across axes of knowledge. You could also think about these across axes of the types of work people are engaged in who have more limited education. So this is 2/3 of the excess deaths in California have occurred in those without a high school degree, with only a high school degree or less. These are figures from our earlier papers, but we've just redone these, and you see this consistently throughout the entire pandemic. You see this across every racial and ethnic group, and really this is a pandemic where the issues of class, the issues of who is doing frontline essential work, who has the knowledge and access to other resources to protect themselves and keep themselves safe, have really dictated who is at risk of dying during this pandemic. It's not just race and ethnicity, of course. It has to do even within a particular racial and ethnic group. We know that other factors really are associated with the likelihood of dying. Here in this case, it's not just being a Latino in California, but those who are born outside of California, more recent immigrants are at highest risk of excess mortality. And you can look at this together by looking in this bottom panel at US born and foreign born. And then if we look in the essential sectors and the non-essential sectors, it is those who are doing the frontline essential work and who are foreign born. And we'll talk about this a little bit more, really having the highest risk of excess mortality. So this is work that has been led by Yehang Chen, who's a really outstanding research scientist and a graduate of our PhD program in the department. And much of this is also the work of Alicia Riley, who was a postdoc with us and is now a new professor at UC Santa Cruz. So she's been doing a lot of work in the farm worker community and has been looking at observed versus expected deaths in the farm worker community in the Central Valley. And this is during last summer months. And what she's showing here, I want to highlight two things. One is the high excess mortality during the summer months in the Central Valley that you're probably all familiar with. And then I would also, and the observed deaths are here, and the expected deaths based on prior years are in gray, and then the excess, and you can see the market excess here. And what she's showing here is really giving us a better understanding of who are the farm workers who are actually dying. So 85% of the working age farm workers who died of COVID-19 had less than a high school education, 69% less than a ninth grade education. And importantly, the average working age farm worker who died of COVID-19 has spent 24 years on the job. So these are people, families, communities that really are part of our California economy, part of our California livelihood and communities, but really bore a substantially disproportionate burden during the pandemic. One of the things that I haven't shown you here is also how much, when we start to scrutinize the causes of death here, how the excess deaths really far exceed the COVID-19 diagnosed deaths. And there's some hint here that much of that at least early on in the pandemic, that some proportion of this is undiagnosed COVID, that there's some degree to which there is people who are not being tested, who are dying outside of the hospital, oftentimes for an etiology that probably we don't define or document very well. And lots of the work that we're focused on right now in particularly more marginalized communities is trying to understand how much of this may be undiagnosed COVID. There are intersecting structures of disadvantage that really help us to at least understand the mechanisms at work that might put foreign-born Latinos, particularly those in the farm working economies, at particular disadvantage. This is low-wage work. This was work that was oftentimes unprotected, so no access to personal protective equipment. These are populations with low formal schooling, with limited English proficiency, and then oftentimes unauthorized legal status, which both puts these communities in positions of less empowerment to be able to demand more workplace protection, but also lack of access to the types of government protections, financial relief that was in place to try to help mitigate the effects of the pandemic in more low-income communities. So much of this is, of course, tied to essential work. And we realized early on that there was not a lot of data about essential workers. Occupation is one of these things we don't collect very well in our clinical settings. We don't collect very well in our public health settings. It turns out that on death certificates, they do actually collect information about occupation. And colleagues of ours suggested that because we had access to the death certificate data, we should look at occupation. We recognize there's, of course, lots of limitation to how occupation might be coded in a death certificate, but because there was so little other work, large-scale work that was being done in this area, that we wanted to report this. And so we looked across those essential sectors. Essential sectors were actually designated by the governor. These are sectors that could be in person, that were essential to a functioning California economy, and that we are looking now here among working age adults, and we're saying within these sectors, amongst working age adults, there's an expected rate of death that we know would have occurred based on the prior years. How much did our death rates during these months of the pandemic exceed those? And you can see that across the top 4 sectors, facilities, food and agriculture, manufacturing and transportation and logistics, these death rates are substantially higher. And remember, these are among working age, younger people, and we're already accounting for any type of higher risk that might occur because you're a truck driver, for example, and doing long-range trucking. It is interesting when one looks at this and now starts to disaggregate and tries to understand our usual way of discussing inequities, which is through a race ethnicity lens, when we overlay the impact of these occupational sectors. So you see down here on the rows, the different occupational sectors and their higher risk. So the way you read this is to understand that among all sectors, there's a 22% increased risk of dying of any cause, a higher risk of dying during the pandemic amongst those who are 18 to 65. If you worked in food and agriculture, that excess risk is about 40% higher. And you can see all of these as you go down the list here. Let's look across by race and ethnicity. I've already told you that Latinos have the highest excess mortality here, a 36% increase compared to 22% overall. But then let's look at the sectors, and then you can see where the substantial increase lies. Amongst Latinos, if you're working in food and agriculture, your risk of dying during the pandemic is 60% higher than Latinos in food and agriculture in any of the prior years. Food and agriculture here are people who are working in the restaurants, they're people who are working in the fields, and people who are working in the meat packing plants, which we know are oftentimes have been sources of outbreaks. You can see here for Black Californians, 36% increased risk. This is in retail. This is in the grocery sector. You can see here the value of disaggregating data, because when we look just at Asian populations just aggregated overall, Asian Californians, we see not a substantially higher risk than overall. And when we look at health and emergency workers, we also don't see a substantially higher risk overall. But when we look at Asian Californians who are in the health and emergency sector, we see a substantially higher risk. And this is higher, this is the occupational sector that puts Asian Californians at highest risk. And I think many have now highlighted the risk of Asian nurses, particularly Filipino nurses, in the healthcare sectors. We know that many of the healthcare sectors are actually protected because of enhanced PPE and other types of things, but that there are many in the informal healthcare sector who are doing home care, or in the formal sector who are in nursing homes, that a lot of the lower wage healthcare work in these sectors also, those are populations at higher risk. And you see amongst white Californians, the sector that's at highest is food and agriculture. So we wrote about this at the end of last summer, saying that really the pandemic has divided California into two. There are those of us who are protected, who do mostly remote work, come into work, and as we do in the healthcare professions, but oftentimes but have access to the types of PPE in general that can keep us safe, the types of testing that can keep us safe. And in our city of San Francisco, we've had fairly muted rates of COVID-19 throughout, but the tenfold difference in rates between the southeast sector of the city and the rest of the city. So really a very different experience from people who don't know anyone who's died of the pandemic and communities where many people have been sick and died during the pandemic. So this is the quote from Sir Angus Deaton, who is the Nobel laureate and the Princeton economist who writes about diseases of despair and the origins of health inequalities, who says, averages have no consolation to those who have been left behind. And it's when we think about the pandemic as the average response in California, we have actually as a state done fairly well. When we look at what those averages hide, I think it's where we understand the important stories behind the pandemic. So the reflection here I would first make is that throughout the pandemic, we've observed stark disparities that are deeply rooted in pre-existing social and structural inequities, that the disproportionate burden of COVID-19 on poor and minoritized community was predictable. It was predicted by those who think about pandemics and could have been planned for, and that failure to focus on equity in our pandemic management has limited the overall effectiveness of our response, both because these minoritized communities represent a large proportion of the California population, and because of our substantial interconnectedness of our communities, and the fact that we have a communicable disease, that it is failure to focus on equity in front and center in this pandemic that has really limited the overall effectiveness in this response. This is, I would recommend to all of you, if you don't read Ed Yong, you're really missing out on a really brilliant writer in The Atlantic who has really crystallized the essential elements of the pandemic throughout. And this is a really wonderful essay and has this quote from Dr. Mary Bassett, who says, you know, infectious disease can spread from the vulnerable to the privileged. Our inequality makes me vulnerable. And that's not a necessary feature of our lives. It can be changed. So what I'd want to argue is that an equitable response is in fact an effective response. This is not just something we add on, but something that if we were to put it front and center would actually lead to more effective response. So what I want to talk about then briefly is what characterizes the bright spots in the pandemic. So where have we seen some ways of thinking differently about health inequities? And I'm going to focus on our county because that's what I know and the most. I know there is good work going on throughout the county, and including in San Diego. And so I don't want to only blow our own horn. I'm just talking about the things that I know the best here. So many of my colleagues at San Francisco General Hospital, mostly clinicians who saw actually the patients who were in our hospital, realized that we had to have interventions in our communities that we saw being most affected. This is a partnership called Unidos en Salud, which is a partnership with the Latino Task Force that has brought together community organizations, businesses in the Mission District in San Francisco. This is really led by Drs. Diane Havlier, Karina Marquez, Gabe Cheney, all infectious disease experts who use their experience during the HIV epidemic to really think about community mobilization. And during the early lockdown, said we will actually need numbers. We need to know who's being affected, and we need to know in these communities that our own anecdotal experience as physicians were telling us we're going to be disproportionately affected. So this team basically said, let's survey this one census tract in San Francisco in the Mission District and let us do this during the lockdown. They got permission basically from the Department of Public Health and went and knocked on every door in the middle of the lockdown and basically went to get people tested. This is really a partnership and a really strong, and you'll see a strong over time effective coalition. This was about not just testing, but test and respond. This was about the wraparound services that needed to also happen, and about investing in the community organizations that were going to be doing the types of responding, making sure that we had isolation, quarantine, education, and resources for people to be able to do this. They found a high demand of testing. It's always striking to me to think about this, that this 4-day testing blitz that my colleagues engaged in at that time represented 30% of all the tests that had been done in San Francisco. Was really this mobilization to understand essentially the prevalence of COVID-19 in the Latino community. So what they found here is that that although this census tract is about half Latino, half mostly white, that all of the positive results were amongst the Latinx residents within this population. They showed that what we know now, that most of those who were PCR positive were not symptomatic, and that they showed the importance of essential work, that these were not people who could work from home. These were people out doing frontline in-person work, or who were unemployed or furloughed and looking for work. So people out and about in the midst of the lockdown. There's been a great collaboration with virologists in the Chan Zuckerberg BioHub, particularly Joe DeRisi, to actually do mapping and genotyping to understand both patterns of transmission and over time in these testing operations to really understand the rise of new variants. And this has been a really fruitful collaboration from that perspective as well. So the summary of the mission study was that that they showed the prevalence of, which was high at this time in the pandemic, that there were multiple strains, that they were distributed unequally in the population, even though people were residing within a same multi-block radius, that being low-wage Latinx community members who were unable to shelter in place, who are living in high-density housing, were most likely to be affected. What I've been struck by is how over time now multiple testing events and actually giving data back to these very robust community coalition in partnership also with the Department of Public Health and the city has led to actually substantial policy changes as a result. So here's some impacts of the findings. So they basically showed that if you lower barriers to testing, that people can come out to be testing. And it led to many more community sites for testing. And this has been a theme throughout the pandemic. They showed, before we knew, at least in San Francisco, and we didn't really know nationally, that that symptomatic testing was going to be insufficient. This effort actually led to the changing in our testing criteria in San Francisco to make sure that in all the public health sites we were testing asymptomatic patients. We showed that loss of wages was a barrier, and that led to actually a large philanthropic effort to raise funds for a right to recover fund, and then eventually the right to recover legislation, so that if you were a low-wage worker who had to take off to be for isolation or quarantine, that you actually could have a recovery of your wages. And this has really become a model both for other efforts within San Francisco and for other places across the country. This is work led by my colleague Kim Rhodes, who's really focused on the African-American communities in the Bay Area, again, with a very similar model of Unidos en Salud, of a coalition of community organizations, really with UCSF as using what we do the best, which is help to provide data and to mobilize the types of technical expertise that we need for these types of testing efforts. But really, this is about community-led coalition and lowering the barrier for access to testing. The African-American community in the Bay Area is much more dispersed, and so the model that Unidos en Salud used was not going to work for Umoja Health. And so Umoja has adopted much more of a pop-up model of testing to really go where the community needs are based on the needs identified by this strong coalition. And we've now shown, I think, several times, I'm not going to show the work that's led by Dr. Margaret Kuschel, who has employed these same techniques to really expand testing and eventually vaccinations in the marginally housed and unhoused populations, particularly in the Tenderloin. We've learned a lot doing these across multiple different coalition building. We've learned a lot sharing our experiences with each other and building a backbone infrastructure to allow all of these different community-led coalitions to benefit from very similar type of infrastructure that's created some efficiencies. We've written about this in our community academic partnerships piece in JAMA and New England Journal of Medicine Catalyst. What we think were the essential features to all of these efforts, even though they're very different in the way that they have ultimately been operationalized, is that they are all rely heavily on a strong multi-sector coalition that really is community-led, that this has focused less on just administering testing or doing vaccinations, but is focused a lot on the wraparound services that are really administered by the community organizations. And ultimately, this is about investment in the community organizations. This is the stationary site for testing at the BART station in the Mission District. And they not only do the testing, but have now started and really have moved into diabetes screening, because that was what the community wanted. It is what the clinicians who were involved thought would be the next phase. And I think they are looking at sustainability for multiple health needs in these communities. This has always been about data. UCSF is good at collecting data, providing data, and that data has been both useful to community advocates and community organizations to advocate for policy changes that affect their communities, as well as to the departments of public health. And our goal is for these robust coalitions to hopefully be part of the partnerships that we can use to continue to address health needs in these communities over time. One of the things that I've been really pleased with is the opportunity to work with the California Department of Public Health. And I think you see how California has been thinking across the state level about how we build in focus on equity over time. And California is one of the states that, amongst the few states in the nation, that adopted actually metrics related to equity that were tied to some aspects of the pandemic response. And so, that average case rate within a county is something that masks the disparate impact within the county. And so for a period of time, the state had built in metrics that said, you not just have to get your transmission down, but you also have to make sure that those communities with the highest transmission are not substantial outliers to your overall transmission rate. So this is one of a few examples of not only measuring differences across the community, but building in metrics and accountability to tie reopening to an attention and focus to those communities. So in the Bay Area, 4 of our counties fell short. This was during last fall, and then had to think with community leaders and with departments of public health how to address transmission in those communities. That's what these metrics are designed from a policy standpoint to do. We wrote about this, and I think you will start to see, and we're already seeing, every group I'm invited to around the country, whether it's on the clinical side or on the public health side, I think is thinking much more about how we build in metrics that hold our systems and our policies accountable to the principles of equity. Unless we do this, it doesn't quite might happen. And I think you're going to see more of a discussion of how we do this. It's not easy to do this. And on the health system side, we also know it's not easy to do this. Our Health Equity Council at UCSF Health has also been thinking about this. But this is much of what we do in healthcare is ultimately driven and incentivized by our accountability metrics. And I think you're going to see more of this over time. We've been fortunate to develop a strong collaboration between CDPH and our UC-wide sets of investigators who are doing work in COVID. And this is a collaboration between the California Department of Public Health and UC to basically make COVID data available to UC investigators. And if any of you are doing this type of work, I think you will see more of opportunities over time. And I'd urge you to check out this website to see how you might access that type of data. So some of the work that we've done, I think, both because we and many others are doing work and trying to do this in a timely way to inform public policy, I think has really, and the close collaboration has actually led to shifts in how policy has been conceptualized in California and nationally. So this is, again, the occupational health study that was led by Ye-Hung Chen. He called me when he finished the analysis and he said, I'm going to post this on the preprint server. I'm not going to wait for this to be published. And I said, sure. I had very limited experience with preprint servers, but he and Maria Glimor, who's one of our fantastic faculty, developed this figure basically to show which occupations had the highest excess mortality during the pandemic. And they published the paper on the preprint server. And this particular figure gained a lot of attention in the popular press. It gained a lot of attention on social media. And I think it really highlighted and crystallized what we all sort of intuitively knew, that people who had to work in person were at higher risk, but it sort of put numbers to and specific names to the types of occupations that were at high risk. And then you did see some policy changes. So as we've talked to vaccine eligibility, food and agricultural workers really have been called out. And I think we've seen that both in the early stages of the vaccine. You see that in the Biden administration in how they have prioritized some of their financial relief also to this sector. I think calls back to both this work that Ye-Hung Chen led, which they called out in their report, as well as those who many others have now shown in much more detailed work how the essential occupations really have borne the brunt. We've tried to talk about strategies that could be more equitable, that as we're thinking about vaccine rollouts, and of course, we are now thinking again about vaccine rollouts, whether it's boosters or childhood vaccinations for COVID, how we think in a more geographically defined way and make sure that geographically we recognize those communities that might be more vulnerable and use our information about geographic location to actually make sure that access to vaccines is available there. And we wrote about this in February at the start. This is work that we've been engaged with the Minnesota Department of Public Health and colleagues to say across our two states, if we compare our strategies for delivering vaccines to either focus only on age as the high priority or to focus on age and communities that are more vulnerable because of many of these social vulnerability indices, which would lead to a more equitable distribution of vaccinations. And we're comparing Minnesota and California, two very different states, but in each state trying to understand that the patterns, particularly in non-white populations of who has died of COVID, has really showed how in many of the non-white populations, you show a younger age in the distribution of deaths. And that means that if you are vaccinating only on an older age criteria, you are not vaccinating the very populations that have died at younger ages during the pandemic. And so in this work, trying to do the detailed analysis to suggest that geographically targeting, when used in combination with age targeting in our vaccine allocation, can actually lead to a much more equitable distribution over time. So vaccinating in the places hard hit by COVID is sort of a major theme. This is one that our clinical colleagues who are focused on delivery to our clinical locations really focused on. San Francisco focused in this area. And you can see that, that they actually matched the distribution of vaccines very, very well with the distribution of those communities that had been affected by COVID-19. And this is just a reprise of the work that, Unidos en Salud has done. They transitioned from vaccinations to a stationary testing site. This is in the Mission. It is because they have had this long-standing partnership. This is a place that from the very outset was far exceeding the capacity of the vaccinations that were delivered to this site. And they have, because they had developed the trust, they were a recognized site, they worked in partnership with the businesses in the area, and really have been phenomenally effective along with other avenues to make sure that we are vaccinating these communities. And in San Francisco, our Latino population has actually amongst the highest rates of vaccinations, and this number has only increased over time. The lowest in San Francisco is actually our white population right now, and as we're working to try to improve all of these rates, I think we know we still have a lot more to do, but we're actually quite happy that many of the communities that have been most affected during the pandemic have also now starting to see amongst the highest vaccination rates. There's still more work to do. We know across the state that the distribution, when you look here by the communities that are less healthy based on these vulnerability indices, are more healthy, that we have gaps here in the vaccination rates across the state. And you can see here, this is from September, but the same holds true, is that while we as a state have done better than the states that bore the brunt during the summer months, which have been really in the southeast part of the state, that this is really very much a coastal urban phenomenon of having high vaccination rates, that once you move inland, you realize that, that parts of our state have amongst the highest hospitalization rates outside of the South that were very heavily affected. And it's these types of persistent differences in how we as a state operate that I think will speak to how we weather our winter months now. So what are the elements of an equitable pandemic response? The recognition that equity is a moral imperative and critical to effectiveness. The partnerships, the key multi-sector partnerships, ideally those partnerships that don't just develop during a crisis, but actually have been there over time. Our goal is to keep our partnerships together to continue those and hopefully sustain those going forward. These are community partnerships, they're multi-sector coalitions, and we're really pleased by the partnerships between our academic health systems partnerships and public health. Data to inform policy is always going to be critical. And I think one of the themes you're going to hear more of is how we use data, particularly to understand health equity, and that these data have to inform metrics and accountability. And I think we'll continue to see this both on the clinical side of the house as well as the public health side of the house. So this time must be different. It wasn't really quite different, but I think we did see some aspects of the pandemic that did start to show where we need to be going. And it is my hope that we continue to learn from this and figure out how we can build in equity into everything that we do. And I just am reminded always of one of our physicians who recognized who is responsible for so much of what we think about in clinical medicine, but also who is one of our are champions of the social factors that that really ultimately govern how we see these patterns of health and disease. And the answer to the question of how to prevent future outbreaks is quite simple: education together with its daughters, freedom and welfare. In practice, it's more difficult to see how a social problem is solved. For us to be perfectly clear, we are confronting the fundamental problem of attempting to understand these factors which made us what we are and which will determine our future. So really speaking to these broad structural forces that need a lot to shape them and move them, but I think also recognizing that those who do clinical medicine or public health medicine really need to understand and recognize these factors and figure out how we play our role to shift our focus on equity in order to achieve the outcomes that we all hope to achieve. So with that, I'm happy to take questions, and I'm going to stop sharing, I think, so we can take questions if that's okay.
Dr. Bibbins-Domingo, thank you for that incredible presentation. Just very enlightening and just such important work. We do have some questions.
Great.
First from Dr. Mandel. The differential COVID data by occupation is very interesting. How do you adjust for the fact that infections in these individuals are a mix of what occurs in and out of the workplace, and differences in risk factors for non-occupational COVID that may be unbalanced among different occupations?
So you are 100% right. And the way we write it, we don't adjust for it. So the way we write about it is to say, these are higher rates of death than we anticipate. I do not know that this is COVID acquired in the workplace, but I do know that these workplace factors are associated with higher excess mortality. And so in some ways, it doesn't quite matter whether it is acquired in the workplace or it is just a marker, because the person who might work in food and agriculture had someone else bring it into a densely populated household. It is not the type of data you need to understand exactly how to mitigate a workplace exposure, right? There you need much more detailed epidemiological data on what's happening actually in the workplace. But it is a marker. It is a marker of the types of factors that in the populations that really have been affected. And I think it is an important marker because it is reasonable to assume that some proportion of the in-person work is in fact transmission. And even though some very likely additional proportion is transmission that's happening because of other social factors like densely populated housing and those things that put transmission at work. So yes, we need more. And in fact, my biggest thing that when I speak to the epi folks and the people who are trying to collect more data, either on the health system side or in cohorts, is we need more occupation data. It's really just amazing how little we know about occupation as a risk, frankly.
Thank you. And a question from Dr. Tanaka. Wonderful research and presentation. How do you follow up positive findings, particularly in the homeless community? What EHR do you use, and how do you fund EHR costs? Thank you.
Oh, you are so good. Such good questions. So here's the thing that we're excited about is that I think that, so yes, the challenge for the EHR data is legendary. When we were just focused on the EHR, we have spent time thinking about how to use natural language processing to understand homelessness, how to use the social care codes, the social needs code to understand homeless. But when I talked to my colleague, Marga Kushel, who's the expert in this, she says both of those have their limitations. So it turns out that one of the very positive outcomes that we're thinking about is that the city actually collects a lot of data on homeless populations. We just don't use that data together with any other data because data is really siloed in the way we think about this. And the city now, because we've had these partnerships, the city has basically decided and has worked together to link the data on their homeless services with their public health data. And all of a sudden, you can start to see how we can track over time, how we can actually understand vulnerabilities within homeless and marginally housed populations in a way that is really important, because some of this co-occurs with immigrant communities, with non-English speaking communities, with communities by sexual orientation, gender identity, where we have to do specific type of outreach. And that's data that's oftentimes collected actually by those sectors who are looking at homeless, but is hardly ever linked to the healthcare sector data. And that's what one big project we have right now is to actually think about how to link those data so that one could actually do more informed outreach. Over time, what they did when they were trying to do vaccines was to do it manually. They had basically a big, not manually, but to create the data so that they were doing first just J&J trying to get first doses into people, but actually the street teams had data where they had the geographic location of the people who they were giving, the 2-dose vaccine regimens to, so that they could go back out and do that. But I'm hoping that over time we recognize how connecting data across our silos actually helps all of us, clinical, public health, and social services, do our work better.
Dr. Bibbins-Domingo, as a primary care doctor, for those of us who are in our primary care clinics, what do you recommend as steps that we should be taking to try to improve equity amongst our patients and our population?
Wow. Yeah, that's really good. So, I think what we can do in the encounter, in our practice, is to actually really work to understand the lived experiences of our patients, and try to think about how those experiences, which oftentimes are so different from our own, really might have an impact on their health. And to then think about how we work within our clinical settings to mobilize addressing the needs that our patients might be experiencing. But I also think that our role is really to work in partnership with others to advocate towards those larger, broader structural problems that need to be changed. And I think that has been our experience during the pandemic, is to recognize, that we have to do more advocacy on issues related to housing, because our patients actually can't do the isolating and quarantining that we're asking them to do. And I think it's that combination of both thinking one patient at a time, and then thinking about how the structural changes that we have to work to, and advocate for with others over time. I think that is our opportunity. I think there's an increasing recognition about social needs and addressing social needs in the context of clinical practice. And I think it's the role of primary care providers in particular. We're going to be at the forefront of a lot of that. But I think it's our job to always be questioning how we are not stigmatizing, whether we're doing it in a way that's most effective, when we're doing it in a way that's most equitable, because there are some downsides to when we medicalize a lot of these social needs. And I think primary care providers who see this operationalized will be at the forefront of trying to help figure out how that transformation in medicine happens.
Thank you. A question from Dr. Jiang, one of our chief residents. In San Diego, we have a lot of residents who frequently traverse the US-Mexico border. From a health equity perspective, how does or should that impact our pandemic preparedness plans?
Right. Well, yes. So, we start with the U.S. inequities, and then, of course, that is nothing compared to the global inequities. So what I know is that I know from the way California approached this, that it was a complete blind spot, apparently, that we did have so many people transversing. And so we made big mistakes early on of just not even planning for the number of people, many of whom are American citizens, that live across the border that we didn't even plan for. The fact that people are freely mobile, they are moving across the borders. The systems overload in Imperial County, most people say is because they planned for a population of 200,000 where they really had a population that's being served of about 500,000. And so we are not doing our job if we cannot understand what we need to do across the border, both recognizing the population and recognizing that in our border communities, unless we figure out access and equity issues in prevention and in access to treatment, that it's not going to serve us well. So I think we actually actively have to be doing that, and it is a big blind spot. One of the things that I'm really pleased by, though, is that if you and I think I think the Chronicle, San Francisco Chronicle, just did a wonderful piece. You also see, the responses to the pandemic that have worked well have been very local sometimes, and I think that they're the ones that where the local communities, they know what the patterns are. They designed their patterns to accomplish that, and so you see both in the Central Valley and in Imperial County these extraordinarily high rates of vaccination now, in part because they're just like, well, we have to do something that is going to actually recognize that we have a lot of movement back and forth. I would hope that we could think through better systemic solutions. There's, of course, lots of political considerations that always make that challenging, but it does seem to me that local communities are figuring it out in a way that recognizes the reality.
Thank you. And one final question from Dr. Rubin. My question is related to case identification and being more proactive with neighborhood testing. Has sewage wastage been used to monitor COVID-19 exposure in particular neighborhoods and target those areas? That's something I know UCSD has been doing on our university campus.
So we have a granted, because our colleagues at Berkeley have been doing this, and we have been working with them, and we're very intrigued, and we hope we get funded to do this. We're very intrigued to figure out the equity angle on that, right? Because what you would like if we reached a new steady state in the pandemic is for the access to testing to not to be the barrier to seeing a signal of new rise in transmission, that something like passive wastewater collection might do that. And we have some hints that might be the case. It turns out that there's a lot of epi-surveillance numbers that we need to figure out, like how good is it going to be and when will it work the best. But we sort of like it because we do need a means to identify when there's a problem in a way that doesn't rely on people, for a whole variety of access issues might prevent, actually testing to be the first signal. So I'm a fan of this. I just hope more people who do wastewater try to think about the equity angle, because I think there's a lot of opportunity there.
Dr. Bibbins-Domingo, we are so grateful to you for sharing this important work with us. Thank you so much for coming and visiting us virtually, and we look forward to hearing from you again soon.
Thank you so much. Have a great day.
Thank you. I hope that all of you will join us again next week for Department of Medicine Grand Rounds. Thank you.